Welcome to this professional education series on medical necessity and insurance approvals. We are designed for clinicians, revenue cycle teams, and health plan professionals. This video will define medical necessity, examine real U.S. cases and data, and walk through field-tested playbooks for both hospitals and payers. This series serves as a bridge for the two sides of the approval conversation. By the end, you will be able to define necessity operationally, narrate the decision pipeline, cite current federal data and landmark cases, apply denial prevention best practices, and align your programs with upcoming federal requirements. We have structured this into 6 parts. We begin with foundations and the mechanics of decision-making. We then move to evidence and legal cases, the 2024 to 2027 regulatory reset, and finally, actionable playbooks for both hospital and payer teams to help reduce friction and improve alignment. Part 1 establishes our foundations. Before we can debate approvals, we must establish a shared vocabulary. We will cover the core definitions, the legal anchors used in the U.S. health system, and the evidence base that justifies why utilization review exists in its current form. At the heart of the system is the Social Security Act's definition of reasonable and necessary. Most commercial contracts mirror this, adding requirements for clinical appropriateness and a bar on convenience-based services. Remember, necessity and coverage are 2 separate gates that must both be cleared for approval. Many disputes stem from an operational definition problem. Following Deming's quality principles, a definition is only functional when all parties agree on the criterion, the test, and the outcome. If you are not naming the specific criteria set, version, and indicator in your request or denial, you are inviting conflict. Most payers apply a 5-part test to determine necessity. Is the care evidence-based, clinically appropriate, not for convenience, not experimental, and cost-effective? Documenting these 5 factors clearly in your notes before a review is even initiated is the most effective way to prevent denials. The scale of this process is massive. With over 50 million Medicare Advantage authorizations per year and a 15% industry average initial denial rate, the process involves a distinct chain of command. From the treating clinician to the medical director and regulators, every role has a specific impact. Your practice must be grounded in the appropriate legal anchor, whether it is the Medicare statute, ERISA rules for employer plans, ACA appeal protections, or state-specific laws like, quote, gold card programs or AI transparency requirements. Understanding the specific regulatory framework is vital for managing your case. Evidence-based medicine is our only truly shared language. With medical knowledge doubling rapidly, criteria sets must be current to be valid. In your appeals, always target any drift between the reviewer's criteria and current clinical guidelines. If a criteria set lacks a version date, it is likely already obsolete. Variations in care, as documented by decades of research, are the historical justification for utilization management. However, variation only justifies targeted review of true outliers, not blanket friction for everyone. Guideline concordant care remains the clinician's strongest shield against unnecessary scrutiny. Review programs should aim to reduce low-value care, which accounts for a significant slice of annual waste. However, if the administrative cost of the review itself exceeds the savings, the system is simply relocating waste. A design rule: ensure every review program creates more value than it consumes in administration. We are now moving into Part 2, how approval decisions are made. We will explore the internal mechanics of the system, including review types, program rules, and the anatomy of a determination. While program specifics vary across the country, the underlying skeleton of the process is universal. Utilization management operates in 3 moments: prospective, concurrent, and retrospective. Prospective review occurs before service, creating the most friction. Concurrent review happens during the stay, and retrospective review audits the claim afterward. Each stage carries different leverage and different consequences for the patient and provider. The physician workload is substantial, with average practitioners spending 13 hours a week on authorizations. With reports of rising denials and the looming impact of AI-driven reviews, understanding these volumes is essential. Any meaningful reform, whether voluntary or federal, must address this daily operational burden. Let's explore the criteria sets. 2 libraries dominate American review: InterQual and MCG Health. You also face plan-authored medical policies. In any dispute, insist on 4 details: the name, the version, the specific indicator missed, and the specialty of the reviewer. You have the right to argue against the actual text. not a paraphrase. Medicare sets the standard. Traditional Medicare uses public NCDs and LCDs and the Two-Midnight Rule. The 2024 CMS 4201F rule forced a reset for Medicare Advantage. Plans must mirror traditional Medicare coverage, internal criteria must be public, and I cannot be the sole basis for any denial. Medicaid managed care offers the broadest coverage for children under EPSDT rules, but often suffers from poor appeal rates due to unreadable notices. Meanwhile, ACA marketplace plans show high variance in denial rates, often with fewer than 5% of denials actually coded as medical necessity. The determination pipeline has 5 stations: submission, nurse review, physician review, peer-to-peer, and final determination. From 2026, federal floors mandate tight clocks, 72 hours for expedited or 7 days for standard. Remember, what you provide at the submission station dictates the later stages of the process. Why are claims denied? Data shows that rarely is it truly about medicine. Only 1 in 20 is coded as a medical necessity issue. The rest are administrative, eligibility, or data gaps. Most denials are preventable upstream, before a clinical argument even starts. When you must appeal, follow the ladder: internal appeal, external review, program-specific paths, and finally, litigation. The professional's habit is to build the internal appeal for the independent reader at the next rung. Use precise indicators and current citations. It is the most effective way to secure a reversal. Moving to Part 3, Real-World Evidence in Cases. We will analyze national physician surveys, federal audits of actual denials, the striking paradox between overturn rates and appeal rates, and 2 landmark case files: Cigna's PxDx and UnitedHealth's HHPredict. The AMA survey is clear. 95% of physicians report that prior authorization delays necessary care, and a quarter report serious adverse events. Notably, 88% believe these requirements actually increase overall utilization, a sign that the current system is generating more friction than value. Federal auditors conducted a re-review of denied Medicare Advantage requests and found that 13% of the denied PA requests actually met Medicare coverage rules. The failures were mundane: manual errors, strict internal criteria, and ignored documentation. This audit is the backbone of current federal reform. Consider the appeal paradox. Denial rates for Medicare Advantage are around 8%, but when appealed, over 80% are overturned. Yet, only 1 in 9 denials is ever challenged. This suggests that silence is frequently mistaken for accuracy, and clinicians should treat appeals as a vital duty. Case File 1, Cigna's PxDx. Reports alleged automated batches of denials without individual review. Cigna maintains PxDx is simple code matching and not AI, and that most claims are approved. A court allowed these claims to proceed, highlighting that batch processing cannot replace the required individualized clinical review. Case File 2, UnitedHealth and HHPredict. Allegations centered on the use of predictive modeling for post-acute care. Senate investigations found high reversal rates on appealed denials, suggesting a reliance on models over individual judgment. Courts are now ordering transparency into how these predictive models function. The legal environment is shifting. Courts are reinforcing that breach of contract claims exist alongside Medicare rules, and states like California and Texas are mandating human-first reviews and transparency. The rule is becoming clear. Models can inform, but humans must decide and document. The financial cost is staggering. Hospitals spend billions annually fighting denials, with over half resulting in eventual payment. This round-trip waste is why regulators are pushing for systemic process fixes. For both provider and payer, the goal must be lean operations that value administrative accuracy over denial volume. In Part 4, we will analyze the 2024 to 2027 regulatory reset. We will discuss the impact of the CMS interoperability and prior authorization rule, the new timeline for decisions, and how public metrics are finally bringing transparency to an opaque industry. Let's see how Washington is rewiring the pipe. Let's examine the CMS 0057F final rule, the most significant federal PA reform to date. Finalized in early 2024, it sets a clear timeline for Medicare Advantage, Medicaid, and federal exchange plans. Prescription drugs fall under a separate rulemaking, but for medical services, the compliance clock is now ticking toward 2027. The rule introduces 2 critical operational changes. First, new decision timeframes: 72 hours for expedited requests and 7 days for standard decisions. Second, It mandates specific denial reasons. The boilerplate "not medically necessary" letter is now obsolete. Plans must provide enough detail for a physician to intelligently resubmit the request. Transparency is now a public metric. Since early 2026, plans must post their approval, denial, and overturn rates. These filings reveal wide variations. Some carriers show single-digit denial rates for Medicare Advantage, while others report over 30% for marketplace products. These numbers allow regulators, employers, and providers to benchmark performance like never before. By January 2027, 4 FHIR-based APIs will largely replace the fax machine. These APIs will handle prior authorization, provider access to history, payer-to-payer transfers, and patient access to their own data. Crucially, every exchange creates a time-stamped audit trail, which will significantly streamline dispute resolutions between providers and plans. There remains a tension between industry pledges and physician experience. While dozens of plans pledged voluntary reforms in 2025, subsequent surveys show physicians still report significant administrative burdens. Ultimately, while pledges set the direction, the federal rule sets the floor, and public transparency metrics will act as the final referee. Part 5 explores the hospital playbook for managing denials. High-performing revenue cycle programs treat denials as defects in the system rather than just work to be processed. By applying lean principles, these hospitals focus on governing the process, documenting precisely, preventing errors, and managing appeals as a unified system. Governance is the first step. Federal law requires a utilization review committee, but the best hospitals use this as a chassis. They staff physician advisors who act as a bridge between the bedside and the clinical criteria. They oversee determinations, peer-to-peer discussions, and review denial trends to guide contract negotiation. Documentation is your evidence file. A denial proof note must answer 5 core questions: severity of illness, necessity of the current setting, potential risk of downgrade, response to treatment, and the expected course. Concurrent clinical documentation improvement programs exist to fix these records while the patient is still in the hospital. Standard work is the secret to prevention. With nearly 90% of denials potentially avoidable, the focus must be at the front end, verifying eligibility, confirming authorization requirements, and matching orders to medical policy before service begins. Boring, consistent checklists consistently outperform heroic appeal efforts. Lean methodology teaches us to surface defects in real time. By implementing Andon-style boards for authorization errors and using root cause analysis like the 5 Whys, hospitals can stop issues at the point of origin. A blame-free culture where the team designs the countermeasures is the hallmark of a successful revenue cycle. Run your management process as a PDCA cycle. Plan the focus, do the countermeasures, check the KPIs weekly, and act to standardize successes. Maintain a visible KPI wall tracking denial rates, avoidable percentages, and appeal overturns. Systems only persist when the culture and the operating rhythm are fully aligned. When a denial occurs, follow a 2-move playbook. Move 1 is the peer-to-peer. Take the call quickly, stay grounded in the clinical criteria, and document the reviewer's identity. Move 2 is the appeal. Structure your letter as a 3-line story, followed by evidence-backed, page-cited arguments that make it impossible to say no. Part 6 addresses payer best practices and our path forward. Effective utilization management is a necessary stewardship function. The goal is to protect members without creating needless administrative friction. We will now outline how payers can right-size their review programs, improve transparency, and use automation responsibly. Payers should right-size authorization lists annually, focusing only on areas with high variance or safety risks. Criteria should be transparent, versioned, and evidence-based. Finally, automation should be reserved for approvals. Every adverse determination must be owned by a licensed clinician to ensure accountability and alignment with federal regulations. To close, remember these 7 takeaways. Define necessity operationally, separate necessity from coverage, prevent upstream, appeal systematically, build to federal floors, hospitals must govern, and payers must be transparent. Please share this information with your colleagues. Thank you for watching this series on navigating the modern approval process.